Good morning, everyone. Welcome to our October presentation. It is hard to believe that this is Halloween coming up. We are in the month of Halloween, and right after that, we're going to have Thanksgiving and then Christmas and the celebration of the new year. Just amazing to think this year has gone that fast and that rapidly. And we're hoping that next year we have a little more opportunity to be together, and hopefully our COVID will be tempered down a little bit, and we can spend some time with some folks that we haven't seen for a long time. So anyway, I see most of you are coming on board now, so I think we will get started. Again, welcome. We have a phenomenal presentation with a great speaker again today, presented by WISP, Women Inspiring Scientific Progress. Our presentation today is Epidemics, and we're going to talk about the intersection of opioid overdose, along with COVID-19, and along with race. Should be a very interesting presentation. My name is Suzanne Hensing. If I have not met you, I'm the president of WISP. I'm going to share three very quick things with you because we have so much information to cover today about our epidemics. First of all, I'm going to share a little bit about WISP with you, just what WISP is, if you don't already know, and if you already know, please bear with me. Second, how to join and the benefits of WISP. And third, a little bit about today's presentation. So I'm going to start, first of all, and talk to you just very briefly about WISP. The history of WISP goes back about 8 years or so, and currently we are 55 women strong. We have a mission that we work closely with Banner Health, and it provides education. WISP provides education and philanthropic support, focusing on women's and families' health. And that's exactly what we do, we have been doing, and we will do in the future. And we've been meeting, doing some strategic planning, and so stay tuned for some new exciting news that will come out in December about WISP. WISP typically has a session once every other month, but recently, because of COVID, we've been meeting about once a month or so. We have evidence-based educational programs. We talk about disease processes, health prevention, and we talk about treatment. The end of the year, we typically have an annual fast-pitch process where we give back funds to the folks that presented to us. We give back funds to their departments or to their institutes at the end of the year, to those who presented to us during the year. That's our philanthropic arm, and it's very exciting, and it'll be on December 4th of this year. So you've got to join us for that. The members get to participate in that session. Second thing I wanted to let you know is how you join WISP. I'm going to let you know that at the end of the presentation today, you'll receive an email. It's kind of a thank you email, and there's lots of information in that email. You're going to have a listing of the future presentations, and I might just mention our next one is on November 17th, and it is about integrative medicine and alternative medicine as related to the treatment of cancer. And it's a doozy. It's actually very, very, very good. I'm sure all of us have been affected by someone with that's had cancer, or a friend that's had cancer, and alternative medicine, integrative medicine is very, very effective for these folks, for their pain meds and their psychological well-being. Also in that email, you're going to see how to join WISP. It's $1,000 for a year. It's $1,000 well worth your time and money. You'll learn about healthcare issues, leading edge research that's going on at Banner University Medical Center and in Phoenix and in Tucson. You're going to learn about the resources that are available to you in Phoenix and in Tucson. And you're going to meet wonderful women. There's a whole network of women that will be behind you, and that's one of the biggest assets that you will find. So those are the three benefits to join WISP, and I encourage you to do so. That'll all be included in that email that you'll receive. The third thing I wanted to share with you is a little bit about today. Just a few updates. You're going to see three faces on the screen. I think you see them right now. You'll see those three faces. The session will be recorded, just so you know that. And I encourage you to ask questions, but you'll ask your questions by writing them in the chat area on your Zoom screen. Write your questions in there, and at the end of the session, I will get your questions and I will present them to our presenter today, and he will answer as many questions as he possibly can. I've asked him to be succinct with his answers so that we can get through some more questions. We typically only get through 2 or 3 because the questions are pretty intense and pretty detailed. So we're going to try to get through quite a few of those questions. I was doing a little research on opioid addiction because I wanted to learn a little bit more about it before today. And I just a couple things that I want to mention. Astounding to me. In the United States, there's 2 million Americans, 2 million that suffer from opioid use. 2 million. It's just astounding to me. And about 130 Americans on the average die every day. 130 every day on the average die. Shocking to me. Then I took it to Arizona, and I looked at Arizona from October of 2018 to September of 2019, just that year period of time. There were 1,389 drug-related overdose deaths in Maricopa County, just in Maricopa County, 1,389. And in 2019, 91% of the overdose deaths involved more than one drug and oftentimes alcohol. And 92% of those overdose deaths were declared accidental. And I think that's what hit me the hardest. These people don't want to die, particularly. They're not committing suicide. It was accidental. They overdosed. They took too much. These are young people, middle-aged people, typically, that are dying. And so I just wanted to share those numbers with you. I know our presenter will have even better, more robust numbers, but gosh, that just shocked me. So with that, I'd like to introduce to you Phyllis Kirk. And Phyllis is a WISP board member as well as the co-chair of the programs committee. And she is going to introduce our wonderful speaker today. Phyllis?
Thank you, Suzanne. And welcome to all of you. We thank you so much for joining us today and hope you are all staying well and taking great care of yourselves. Our topic today is addiction medicine. And we'll talk about how it intersects with race and COVID at this time. So we've all heard so much about COVID in the last 8 to 9 months. We've heard about the disease, we've heard about its progression, current treatment protocols that are currently in place, advancements that have been made in those protocols. There are also many collateral issues that COVID affects. The child abuse rate, suicide, depression, domestic abuse, all of these things intersect with COVID. But today we're going to talk about addiction and how it's intersecting with COVID, in particular to race and the differences in treatment. Our speaker today is Dr. Christopher Peterson. Dr. Peterson is a family practice physician at Banner. After completing a family practice residency at the University of Arizona, Dr. Peterson went on to complete a fellowship in addiction medicine at Swedish Cherry Hill Family Medicine Residency Program in Seattle. Dr. Peterson has developed an outpatient clinic that is integrated into Banner's current family practice center. And we'll hear more about that today from him and what services they have to offer. His interests include integrating addiction into the primary care settings so that the first physicians that typically see patients are educated and able to seek treatment, proper treatment for their patients. He also is very interested in the substance abuse issues in pregnancy. Dr. Peterson also has an interest in transplant addiction medicine, which I hope he'll expound upon in his presentation, and government policy regarding addiction medicine and what's happening in today's current climate. So Dr. Peterson, we welcome you, we thank you, and we look forward to hearing your presentation today. Thank you so much.
Thank you very much, Phyllis, and thank you, Suzanne, for allowing me to come and present to you all today. Let me share my screen and we can begin. I might actually begin with a story. of how I came to this field. I was actually not planning on doing addiction medicine. I like to think of myself as a country boy and grew up on a farm and was planning on going back to a rural area to practice family medicine and full spectrum care. And now I'm completely opposite of that. I'm more doing specialty work in the inner city in Phoenix. And so how did this come about with me is a bit of a story, and it really begins in rural Illinois. I was rotating with a family physician, and at the time was not too long ago, 2011. And at that time, most of my interactions with patients with opioid addiction were in the emergency room setting or the hospital or clinic setting where the patient was asking for opioids from a physician. And a lot of times it was the first encounter. And you could see through medical records that patients had been bouncing from office to office trying to obtain opioids. And for most physicians, this was very aggravating, and it ended up kind of leading to a conflict where patients were asked to leave, they were discharged from clinic, they were treated disparagingly. And so I found it quite astounding when Dr. Aaron Newcomb, who is in Southern Illinois, helped the patients. He recognized addiction, had training to treat it, empathized with it as someone in recovery himself, and so I remember just the compassion he had in our, like, one of the first cases I experienced, where a woman who had been actually getting opioids and snorting them came into clinic asking for more opioids, and he very gently expressed concern about there being a problem with addiction and that he knew how to help her. And after a significant amount of just crying and asking for help and kind of breaking down, he prescribed a medication that stabilized her opioid addiction. It's called buprenorphine. He got her into counseling, which was in the clinic. And within 4 weeks of this rotation, this woman's life completely changed. She went from bordering on homelessness, estranged from her son, unemployed, and at the end of her rope, to a person who had a job, was able to pay her rent and keep her housing, and was making significant strides in touching base with her son and rekindling this relationship. She was a completely different person by the end of really the first week, and certainly by the end of the month that I had seen her. And I was so impressed by how compassion and the right scientific medication delivered to the person at the right time can have an astounding impact. And so I was hooked. And so that kind of began my journey. And now every single day of my work, I'm having these experiences where someone's changing their life. And it's really just a joy to work in this field. My dad, who bless his soul, actually asks me regularly, how are the people having success? Is this even a successful type of treatment? And it is. Folks in addiction treatment have the same amount of success as folks in other chronic disease management. So we're seeing lots of very inspiring stories. I would like to begin with that wonderful story. I'm going to talk about some grim things today, which is the resurgence of overdose deaths during the COVID pandemic and how opioid overdoses intersects with race relations in our country. And so I am doing so to help us to come to some knowledge about these things that are major events. If you poll Americans, COVID-19 and race relations are commonly in the top 10 concerns of 2020. Up until a couple of years ago, opioid overdose deaths were in that upper threshold of concerns, and now it's honestly less than 5% of people polling to say opioid overdose deaths are important to them, which is unfortunate because, as you can see in this graph, the opioid overdose deaths have been rising exponentially the past 3 to 5 years. And there was an improvement in overdose deaths in 2018, but in 2019, COVID-19, we saw a resurgence of opioid overdose deaths, and we actually don't have a good picture of how the COVID-19 epidemic is impacting overdose deaths. But from what we know so far with preliminary data, it's devastating actually, and we'll talk about that. Let's see. So we'll talk about the state of the overdose deaths, this intersection. We'll discuss specific barriers of care that folks face because of the pandemic and because of racial inequities. And then I'll share with you what Banner Health is trying to do about that. So these are some very recent news headlines from around the country and from Arizona, stating about the rise in overdose death rates, and we're seeing these spikes occurring for a number of reasons, but it is quite concerning. I'll pause just for a moment to say that it is interesting that so much attention is being brought to this epidemic when in years past, decades past, drug overdose epidemics have largely been met with vast criminal justice ramifications and legislation, and folks have been institutionalized in our prison systems as opposed to getting treatment. It is thought that as time goes on, we have better science to deliver to folks with addiction. But as we'll talk about further in the race relations section, is that there is concern about how we respond to these epidemics. The opioid epidemic has largely been painted as a white epidemic, with 80% of people dying being white, and 20% of people dying being people who are Black or of indigenous descent or people of color. And so there is definitely already, as we're starting to talk, an inequity between how we've responded to this epidemic with monies and legislation and support, as opposed to incarceration. And I think that it's a moment that we have to ponder our own personal biases, but also we need to make sure that as we are expanding these addiction services, that it's also done in an equitable way. So just a couple quick epidemiologic updates, and we don't have the best data yet, unfortunately, because data for overdoses takes some time to gather. We use the health departments across the country have to confirm the deaths, which sometimes takes months. We usually don't have data for about 12 months. And so any data that I show you now that's in the past 2 years is really preliminary data from the states. But you can start to see that across the country, there's an average of about 17% increase in opioid overdose deaths. In Arizona, that's kind of hits the national statistics, which is concerning with this preliminary data. And it's specifically concerning compared to where we were in 2017 and 18, where we were seeing a decrease in deaths. And then in 18 and 19, we're seeing a resurgence, and so far this year, that's even tripled. I will comment that there are few studies across the country that actually look at the demographics of patients, but one in St. Louis out of Missouri shows a 5% increased deaths in white Americans and a 55% increased deaths in their state with Black Americans. And so we're seeing a significant increase in the amount of overdose death rates amongst our Black Americans. This next slide is interesting. It's the unspoken epidemic that isn't getting as much national attention up until just recently. And that is of the stimulant epidemic, overdose epidemic. About 1 in 4 overdose deaths from drugs in the United States is stimulant involved. And like Suzanne mentioned earlier, actually a majority of overdose deaths in Arizona are polysubstance, meaning they're opioid with prescription pills with alcohol, or benzodiazepine, which is like a sleeping pill, or a stimulant, and stimulants are on the rise. And the complicated thing about stimulants is that unlike opioids, where we have medication therapies that reduce death rates, we don't have medical therapies for stimulant use disorder. We have counseling. We have programs where folks can get, be sober, like sober living, residential programs. But we do miss out on some of the medications for stimulant use disorder, which makes it a little more challenging to treat as opposed to other substances. There is a type of program I'll mention now, and we'll come back to it when we talk about what Banner is doing. But there is a type of counseling program that's highly effective called contingency management. Contingency management is using rewards, monetary rewards, for patients when they have negative drug testing, or they come into clinic, or they complete their programs. And it's these little rewards that they get over time, building up the rewards, that helps them to focus their energies on the behaviors that achieve the reward. Now, giving rewards for abstinence is not good enough. You link that with cognitive therapy so that patients are able to move those monetary rewards to now acknowledging and seeing life's general rewards. And this is a type of therapy that is, as you might imagine, a little bit expensive because you have to fund some reward system, but is the most effective form of treatment for stimulant use disorder. And very few substance treatment centers are doing it because of the expense. Like I said, there's no medications for it. Substance use treatment for stimulants is really just a lot of behavioral therapy. And if you can do this contingency management program, that's always the best. But we lack that ability to deliver that across the country in most treatment centers. Some of the barriers that patients are facing due to COVID-19 are that they're delaying access and treatment. We saw a number of patients accessing addiction treatment during the beginning part of the pandemic, specifically in methadone clinics, because fear of contracting COVID-19 in these treatment centers. We see, as was mentioned earlier, isolation, anxiety, depression because of the isolation and the uncertainty of what's happening. And those are all triggers for recurrent substance use. We see job loss, economic instability, loss of housing, loss of health benefits. You can't even go get treatment if you even wanted it because you've lost your job now. And these all are impacting our patients' recurrent substance use. Some treatment centers have shortened their hours, or even some have closed because of the decreased number and the revenue, which is unfortunate. Mutual health meetings like Alcoholics Anonymous or Narcotics Anonymous are closed for in-person meetings. And a lot of folks are moving towards telehealth meetings, but those without devices or those without technical savvy are no longer able to access and are feeling disenfranchised because they can't go to the meeting down the street that they used to be able to attend. With the isolation has come patients using drugs in isolation as well. Using in isolation causes more drug overdose. I'm always encouraging my patients who are actively using to use with a friend, to not use alone, or to let someone know if they're using so they can check on them. If someone's not checking on them, or they're using by themselves more often, they're more likely to, if they were to overdose, they wouldn't be able to receive life-saving medication like naloxone. So we're seeing increases of overdose because of that reason. Emergency rooms are oftentimes a safety net for patients with substance use disorder. They present there with abscess or withdrawal or psychosis. And our ERs were overrun early 2020 with COVID cases. And with the imbalance of our medical system's focus on COVID and trying to get this pandemic under control, we have let down the guard and have not been as vigilant as what it's appearing in treating opioid use disorder. Interesting as well, the DEA has reported that they're anticipating and seeing limited drug supplies. So patients are running out of their substances using different substances, getting by with what they can, and causing more withdrawal. It might be increasing patients' eventual access to treatment because the drug supply is down, but that is also a very interesting barrier that's occurring. And I'm going to end this section with of COVID-19 and its intersection with opioid use with this quote from Nora Volkow, the director of the National Institute on Drug Abuse. And I can't actually, let me move my, okay. When hospitals are pushed to their capacity, there is added danger of persons with substance use being deprioritized for care if they present with COVID symptoms. It is incumbent on all healthcare workers to not discriminate against patients with substance use disorder and to treat these individuals with compassion and dignity as they would any others. And so it's vitally important right now that we understand this impact and then be able to deliver opioid use disorder treatments, harm reduction treatments to patients during this time period when there's increased mental health burden and decreased access in general. I'm gonna move on to talking a bit about this intersection between addiction and race. And I am very aware how challenging this is to talk about. And I'm gonna do the best that I can with full knowledge that I am not an expert about race. I am in my own learning development at this time as well. And but I do see this happening on a regular basis with our patients and what they express to us. So I'm a firsthand witness to the inequities in addiction treatment and race. And I'm going to define racism as something that's defined from Beverly Tatum, who's the author of Why Are All the Black Kids Sitting Together in the Cafeteria, which is an incredible collection of data and psychological analysis behind racial development and racism and the inequities we see in this country. She defines racism as a system of advantage based on race. Racism is not, it's not necessarily, I guess the image of racism for me growing up was Ku Klux Klan or lynchings and extreme prejudice and violence. And that is not the definition that I am going to be working on today. The definition that I'm working off of is a system of advantage based off of the color of your skin. And I think that's important to note that early on so that what we see happening afterwards, we can kind of put that into this context, okay? There are significant inequities between drug treatment, but there is similar rates of drug use amongst Black and white Americans. It's very well documented that Black and white Americans use substances at the same rate. And yet, the consequence of drug use is pretty vastly different, and the access to treatment is vastly different based off of race. So these are statistics that I will share with you. And I'm gonna start with kind of fairly more recently, 1986, the Drug Abuse Act actually punished the possession of crack cocaine used in Black communities over that of powder cocaine used in white communities by more than 1 to 100 based off of the grams that someone possessed. This led to significant incarceration because of tacked on mandatory minimums because of the possession charges in a very inequitable way because crack cocaine is very similar to powder cocaine. It was just used in different circles. This was partially rectified in 2010 with the signing of the Fair Sentencing Act, which brought it to a little bit more equal level, but still not equal. It's still more like a 1 to 14 gram equivalence right now, but it is much better than the 1 to 100. This in part led to a significant incarceration of Black Americans, that of 6 times that of whites. And we are now living in a time period where 21% of Black males serve prison sentences by the age of 30, compared to 2.5% of white males. And so we see in our country that there is a difference, or what you might say is a system of advantage for white Americans based off of the color of their skin when it comes to drug possession. And this is just a graph of the drug-related arrests between Black and white Americans. And you can see in the 1980s, after the drug abuse, the Anti-Drug Abuse Act was passed, a pretty significant increase in incarcerations for drug charges. And the majority of these are nonviolent drug charges. On to access to treatment. Since the 1970s, opioid treatment has been really the only medical therapy that we've had for the treatment of opioid addiction has been methadone. Methadone actually is one of the most stigmatized treatments in medicine. What's interesting, though, is that the evidence behind using methadone to treat opioids is very, very strong scientific evidence. It decreases drug use. It decreases criminality. It increases job rates. It increases the likelihood of staying in treatment. We really only need to treat about 3 people to keep 1 person in treatment. And if we treat 1,000 people over 1 year, we'll save 25 lives. And so methadone is a very important treatment in opioid addiction. And but unfortunately, because of negative stigma and I think some lack of general education about this medication and the way in which it is delivered, local city ordinances have kind of pushed methadone clinics out of suburbs and into inner city areas, so that most methadone clinics are in the inner city. In 2000, it was discovered that there was a second medication that was very, very effective for treating opioid addiction. That medication is called buprenorphine. Its trade name is Suboxone, which a lot of people know by, but I'll refer to it as buprenorphine for the case of today because I don't want to stay generic. But in the congressional testimony from an expert in addiction medicine, it was stated that methadone was an inappropriate treatment for suburban narcotic addiction, which is a misstatement and which carries with it, I think, some racial stigma about who is deserving of methadone and who is deserving of buprenorphine. Buprenorphine is not delivered the same way methadone is. Methadone is delivered, and this is based off of federal regulations, to patients on a daily basis. You have to go every single day to your clinic. We don't do anything at all like that in medicine, where you go every single day to pick up your medication and you take it. Now there's counseling sessions and peer group and education and drug testing and all sorts of things in addition to that, which make it, which add on to its effectiveness. But buprenorphine is office-based. A family doctor can write this medication. And there is no federal mandate for daily dosing. And so it's much more flexible, and yet is the similar efficacy, meaning it works the same with less rigidity, really, and inflexibility in how the medication is delivered to patients. And so after the Drug Abuse Treatment Act was passed and buprenorphine was made available to patients with opioid addiction, within 3 years, 90% of people who were on buprenorphine were white in the suburbans. And that is because it was targeted and marketed towards the suburban areas by the drug company. It was marketed as a treatment apart from methadone treatment, and really set this stage of difference between who is getting methadone and who is getting buprenorphine. And we see that white Americans are 35 times more likely to receive buprenorphine in private offices or primary care offices or specialty offices as opposed to their Black counterparts. And that Black, Indigenous people of color and people of color are more likely to seek help through primary care, but then be referred to methadone clinics. And we set up this discrepancy that is different in how people get these different treatments, and they have this very similar efficacy, but who is getting treatments is very different. What we are seeing over the course of this opioid epidemic is, and like I think what I mentioned in Missouri, is an increase in the number of Black Americans who are overdosing as opposed to white Americans. So even though more white Americans die every year, the percent increase in deaths of Black Americans is doubling, which is concerning. And we know that Black Americans are more likely to get care in primary care as opposed to specialty clinics. And so some barriers that exist that we've kind of talked about, and more, are that it's known that Black Americans and Indigenous Americans, people of color, trust healthcare system less. And that's from a lot of harms done in previous research studies in the past. We see Black Americans' pain being treated significantly less than white Americans, and they were prescribed opioids significantly less for similar problems than white Americans. We see white women's mortality from pregnancy is higher than that of white women. All kind of adding these things together have created more mistrust in healthcare. They're less likely to access healthcare or have access to healthcare because of insurance. They're less likely to be offered buprenorphine, like we talked about. What's interesting is even though they're accessing and talking to their primary care physicians more about addiction, and that's their preferred route, Black Americans are met with primary care physicians who are not prepared to deliver that type of treatment in the office, like buprenorphine. Very few primary care physicians are trained in it. And so that's a problem. And so they're more likely to be offered more restrictive and sometimes punitive treatments, like for instance, methadone. Now, I have no problems with methadone. I wish methadone was more accessible to everybody. And I wish that it didn't have as many restrictions as it currently does. The laws that govern methadone are, probably 50 years old by now and need to be revamped. There's certainly a fear of a disclosure about substance use because of the significant criminal justice system that is incarcerating many Black Americans. And then there's significant lack of representation. You're sitting here listening to a white doctor talk about addiction. There are not enough people of color in our field. There are not enough people of color in academic medicine or in medicine, period, or in medical schools, and that needs to change. We also are seeing when people are incarcerated, they're not getting evidence-based treatment in prison. They're oftentimes detoxing on the floor of a prison and then going about their time in prison without adequate treatment. And when they finish their time, they oftentimes don't necessarily have adequate follow-up when they leave. And so there's some significant barriers that cause a lot of these racial inequities. I'll bring up this quote, and you may not necessarily agree with it. I think that it's important to remember the first definition of racism, which is a system of advantage based off of race. And Christina Amuda is a medical student and a great activist, and posted this on Twitter. And she really does not appreciate the dual pandemics framing of COVID and racism. Racism isn't a pandemic. It didn't start just this year, but in fact, it is a system of advantage based off of race. She calls it a scaffolding of the modern world and a foundation that these things are built on that have caused such significant inequities. And so we're trying to counteract some of these things. And so we're trying to both, I guess, kind of two things. One is improving access during the pandemic, and two is improving equity here at Banner. And so we are training and supporting primary care physicians. I think that is vastly important in delivering equitable treatment to everyone, is to have every primary care physician able to screen, diagnose, and treat opioid addiction. And so we have every resident coming out of our program is trained to utilize buprenorphine as a modality of treatment. All of our faculty physicians are trained in it, and you know, we will not make a dent, and we have not made a dent in the opioid epidemic by lowering drug prescribing, like opioid prescribing, or expanding detox beds, or even expanding specialty clinics. The only way I feel we're going to make a dent in this is by utilizing primary care physicians who are already experts in chronic disease management, but just give them the tools to do that with addiction. We have opened up telehealth appointments. So we do telehealth video appointments with patients, which has expanded the availability. We received a very generous grant from one of our foundations to utilize contingency management for our stimulant using patients. So we're developing a program to deliver to our patients who are using stimulants. We are developing a patient advisory committee, and this group will help us to understand the impact of this systemic racism that they have felt in their life and in the system and in clinic, so we can start to make different changes to the way that we deliver addiction treatment. We are recruiting diverse team members, both as faculty and as fellows for our program, doing community outreach and education, and advocating for the decriminalization of substance use disorder. We need to treat addiction as a medical problem and not as a criminal justice problem. Otherwise, we will continue to be stuck in the place where we're at. So those are the few things that we're doing. We have an outpatient addiction clinic that sees patients 5 days a week. We provide social services for them. We are doing mental health screening and treatment. We provide primary care for the patients when they need that as well. We have an inpatient addiction consult service. We work closely with the medicine folks in the hospital. We work closely with transplant patients we are trying to prepare them so that their risk for relapse is lower after a transplant. And so we follow them closely and prepare them and to meet the qualifications that the transplant policies have. We have a very robust group to deliver substance use and pregnancy treatment, and received another grant to begin an intensive outpatient program, which is like a 12-week program for pregnant or parenting women. And they'll be getting 9 hours a week of programming and medication and prenatal care. And so that's a very exciting development that we're also having here at Banner University Medical Center, Phoenix. I know my time is low. I want to be able to answer your questions. So I'm going to leave it there and just say, I really am grateful that I was given this opportunity to talk. And hopefully some of these things have been helpful to help you understand the state of the opioid epidemic, how COVID has played a role in that, and how race plays a role in the overdoses, and some of the solutions we're doing. So take your questions.
Very good. Thank you, Dr. Peterson. Don't forget to share your questions with me, and I'll share them with Dr. Peterson. First question here is, typically what happens when an overdose comes into the emergency center, say 7, 8 o'clock at night? Are they sent home? Do they go to the inpatient unit? Are they sent to an outpatient unit? What kind of support services are available for them? And is it based on their health insurance, or the fact they don't have health insurance? You get them on Medicaid right away? What happens typically? Can you explain that?
Great question. So if somebody overdoses, they're given a medication called naloxone, and I would encourage you to actually talk to your physicians about having a kit of naloxone on hand. I think it should be in every glove box and every first aid kit, so even lay people can help intervene in an overdose. But in the hospital, the patients overdose, and then they're assessed medically. If they need to be admitted to the hospital, they get admitted, And we're consulted either through addiction medicine or medical toxicology. We'll start them on buprenorphine or methadone in the hospital and then get them outpatient follow-up. We have a social worker and a nurse navigator that helps navigate that through. If a patient's medically stable for discharge, there's a couple of options. There's a social worker in the ER. They can send them to a treatment facility if they want to. That we have treatment facilities that are actually open 24/7 that will accept these patients. There's an outpatient methadone clinic that actually is open 24/7, and we've partnered with them so that their peers can come into our emergency room and they can assess the patient. And if the patient wants to be started on methadone or Suboxone, they can actually, or buprenorphine, they can go. The peers will actually just drive them to the clinic and get them going. We are actually talking with the ER to see if the ER doctors are interested in actually just starting buprenorphine in the ER. That's pretty much shown in California, upstate New York, Buffalo, Yale, all have programs of starting buprenorphine in the ER, which is highly successful. And so we are working on developing a program and protocol for that as well.
Okay, very good. Next question. Is there any current legislation being looked at to change how methadone is distributed?
There were some actually quite in Arizona, some restricting legislation that passed, unfortunately, this past couple of years. One of the methadone clinics in our community actually is open 24/7, and it brought so much volume that the community around the methadone clinic started to complain, wanted them to get out of their community. And that started out actually the governor's office made a task force that then came up with some solutions for the community. But there was some attached legislation that actually was more restricting for methadone clinics, which is unfortunate. And we hope that legislation doesn't restrict access to these treatments because it makes it harder to get and stay on these medications. Those were like restricting the number of patients per square footage of the facility, which is not an evidence-based practice. It's actually a way to limit the number of patients that are at that clinic, unfortunately. So that's what's happened recently in Arizona.
Very good. Next question. This is a really good question, I think. Is there a diligent effort to monitor those providers who have a high rate of prescribing these opioids on a chronic basis, and then provide those providers with continuing education on alternative treatments for pain? Great question.
Yeah. So a little background, it's really hard to get doctors to change behavior, just like it is with everybody, right? We want to try to change our children's behavior. I've got 4 kids at home, and it's super hard to change behavior. Doctors are pretty ingrained because of their training. And so really the most effective way to change a doctor's behaviors is to compare them with their peers.
Oh, yeah.
And so like sticking up like on the wall, who treated a cold with antibiotics, and like actually having a tally number, that changes doctors' behaviors. And so doctors in Arizona get a monthly report, or a quarterly report from the prescription monitoring program, the pharmacy board, which states how many opioids they're prescribing, how many of their peers are prescribing it, and that is being shown to reduce opioid prescribing. And we're seeing just a general trend in decreasing opioid prescribing across the country and in Arizona, which is a good thing. We've also, because of the Opioid Epidemic Act in 2017, passed legislation requiring physicians to get 3 hours a year of opioid training. And that does include alternatives to pain management. And so there is some work in doing that, but that's not enough, right? That's preventative actions to prevent addiction and deliver pain management in a different way. What we really need are doctors who are taking up the mantle to treat the addiction that's already here, that's already been caused, because those are the patients who are dying. Mm-hmm. And there's in Arizona 3 people dying every day because of opioid overdose.
Mm. Next question, is a contingency management program specific only to stimulant addiction versus opioid addiction, and how could it be used, or can it be used in opioid addiction?
Yeah, it's based off of a psychologic principle of operant learning, which is that if you get a reward for a behavior, you're more likely to do that behavior again. And we use positive reinforcement like that with our children to teach them as they're getting older, and it works for adults in substance use treatment too. And yes, it does actually work in substances other than stimulant use. It just happens to be studied in stimulant use a little bit more regularly because we don't have any other medical therapies for it. But it absolutely does work for opioid use disorder as well.
Okay. I've got a question about the contingency management. Does that work for pretty much any social class? If somebody's doesn't have a lot of money, that may be more of an incentive for them. If somebody perhaps comes from a little bit more wealth, maybe it wouldn't be. I don't know if that's true or not.
That's a really good question. I don't know. I haven't looked at literature about comparing different socioeconomic statuses and contingency management. But I will say that operant learning is also the reason why we scroll through Facebook and Twitter.
Yeah.
It's that like variable reward of maybe seeing a video that I like or seeing a post that I like that keeps you coming back. And we know that all classes of folks are probably using social media too much, but that is the tenet. It is very similar to honestly gambling. In fact, people with gambling addiction are excluded from these trials and these treatments because it is seen as a little bit of a gambling type of a thing. But my gut response is that it works for anybody. And what's interesting is that we actually know the dollar amount per 12 weeks that it works, and it's about $200 to $400 over the course of a 12-week period. Is kind of the targeted amount when you're developing one of these programs. So patients will come into clinic and they'll have a 50% chance of getting $1 or a $5 reward, and then a 13% chance of getting a $10 reward, and then even 5% chance of getting a $20 reward, and then as the reward goes up, the probability is lower and lower to get that reward. And so you make contingent negative drug testing or engagement in treatment. You make those rewards contingent on those behaviors, and you actually see patients following through.
Interesting.
And after the 12 weeks, the effect lingers. So it's like you teach them how to recognize other rewards during this process, and they continue to do that afterwards with success after the treatment.
Super. Thank you. Another question. Are the medications, methadone and say it.
Buprenorphine.
Buprenorphine. Are they both covered by insurance? Medicaid, Medicare, all that, private insurance, are they covered by, totally covered?
Yeah. This is the first year that Medicare has covered methadone. Okay.
Oh,
it's been around since the 70s. Yeah. It's pretty cheap. So patients probably pay $60 a year for $60 a month maybe, or something like that for methadone treatment when they were on Medicare. And maybe it depended on which clinic you went to, but there has been some recent legislation that's changed, opening up methadone as an option for Medicare patients. Long time coming. Buprenorphine is well covered by Arizona Medicaid, and because of the Affordable Care Act, it is mandatory and also what's called the CARA Act, that was a couple of years ago in 2017. These two acts mandated that there has to be a form of medication for addiction treatment for opioids, either methadone or buprenorphine, on every pharmacy's formulary. And so most insurances will cover buprenorphine in some form.
Interesting. Okay. Very good.
And luckily, if you don't have insurance in Arizona, like let's say it's that person that goes to the ER with an overdose, they have no insurance. There's actually state funding through Access. It's kind of emergency funding for methadone or buprenorphine. And there's a couple of treatment centers that have that funding that can provide methadone or buprenorphine to patients who are underinsured or uninsured.
Okay. Very good. Change just a little bit. Babies born of opioid users. What symptoms do they experience? What's the future for those babies? Can you talk about that just a little bit?
Absolutely. I like to use the term passively dependent neonate. We see a lot of negative terminology like crack baby or oxytot or addicted baby. And addiction is a behavioral problem that adults have. addiction is a maladaptive behavior. Passively dependent is a bit more of a scientific and appropriate term for these kiddos who were born either exposed to opioids or like from pain management or non-prescribed opioids or methadone or buprenorphine. About half of babies will have a clinical withdrawal. It'll look shaky, difficulty feeding, difficulty sucking, difficulty gaining weight, but it is 100% treatable condition.
Oh.
And these babies don't suffer. We can put them, we usually do here at Banner, we put them in a NICU and we give them small doses of morphine and we just taper them down off of whatever they were on before. And so it's a treatable thing. It sometimes takes a couple weeks for the kiddo to be completely tapered, but it is actually an area of interest of mine. A colleague of mine from the medical toxicology department, Min King, he and I have started seeing these kids in the hospital, and those families with good social supports and whose moms have been sober on Suboxone or methadone, we actually are tapering them as an outpatient. And so we see them a couple times in clinic. Our nurse navigator is a NICU nurse. She does a lot of education. She follows up with them very regularly. And the mothers actually learn how to dose the medicine at home. And so the moms are dosing the medicine at home. We've been able to cut down on the NICU stay by more than half and get the babies home out of the sterile, cold NICU where they don't belong. They belong in a warm environment. They belong in a home where the mom could hold them and rock them most of the day probably as they're getting through this. And it does not have lasting side effects. Doing this taper and being exposed does not increase addiction. The thing that probably increases addiction in these kids as they grow up is the family history.
Yeah.
60% of the risk of addiction comes from our genes. 60%. I've met lots of people who they got their wisdom teeth pulled out as a teenager. They took one Lortab or one oxycodone pill, and they knew instantly that it was a problem. And that's not a marker of behavioral problems. That's a purely biologic process that just happened after one pill. And some people are just more prone to becoming addicted because of family history and genetics.
So there's no future side effects that these children might experience unless perhaps their mom included cocaine in it and alcohol, huge amounts of alcohol. There may be something there, but other than that, just pure opioid. There are no future consequences, their learning abilities or anything.
Yeah, that's a really great question. And even surprisingly, I know that in the 80s, 70s, and 80s, we were really concerned about the crack epidemic and these kids being significantly impacted by intrauterine exposure to cocaine. But you know what happened to those kids? Many of them went to college. There's been no findings of significant cognitive disorder from crack cocaine or methamphetamine exposure. And this is something that we're finding in literature. The concerns about behavioral problems are overstated. And it really shows how impressive the human mind is and how impressive the baby's brain is, that it can overcome that intrauterine exposure if it grows up in a safe, stable, and sober living environment. So I'm not so much worried about that exposure. What I'm worried about as a clinician treating a mom with substance use is what are you doing these next years, these very just indomitable years of this kid as they grow up? How are they learning? And how are you staying sober for your family and yourself during these periods of time? And what do we need to do to support you during this period of time so that there isn't an effect? Because what affects kids more than drug exposure during the pregnancy is drug exposure in mom and dad growing up. And it doesn't matter if it's mom or dad. They both have significant impact. Interesting.
Wow. Well, there's more questions here, but we're going to stop. Our time is up. I can't thank you enough honestly, for what you're doing. We appreciate what you do. Thank God there are people like you out there that are doing this. And
need more.
So come back again sometime. We really appreciate it. Thank you so much.
Of course. It's my pleasure.
Right.
Thank you so much.
Have a good day, everyone. Thank you. Bye-bye.